I think today was an engaging day with the faculty to really learn about lessons learned from prior clinical trials, and thinking about key endpoints such as overall survival and event-free survival were really important highlights that physicians talked about. We also talked about the importance of understanding the molecular mutation profile that patients with high-risk MDS have, and how that may teach us what might be the best therapy for those individual patients. So I think those were a few of the key take-home points from some of the faculty.
Yeah, and I think a big area of discussion was how to improve our clinical trial design in the future so that we can have a better chance at having successful trials. So some of the key points is that clinical trials continue to be very important because the standard of care treatment continues to be azacitidine or decitabine, the two hypomethylating agents by themselves. And we have had almost a couple of decades now where we are trying to add another drug on top of the azacitidine or decitabine. We see good results early on in early phase trials, but once we go to the big randomized phase 3 trials, we have seen multiple failures. And I think the speakers kind of alluded to the issue is not only with the drugs themselves, but also the way we design the trials have some problems. We talked about some of these issues and how we can fix them, and to work with the regulators and the sponsors to design the trials in a way that makes them more likely to work and show the full benefit of the treatment. But I think the bottom line from a patient perspective is the importance of doing clinical trials to kind of move the field forward and improve the current therapies.
Right now, as we just talked about, the current standard of care for patients with high-risk MDS doesn't yield the results that we would really like to see. It really isn't, and that's one part of why we've had so many trials in the last decade of combining some agent in addition to either azacitidine or decitabine. And so for all of those reasons, we still strongly recommend that patients and caregivers think about clinical trials for patients with high-risk MDS. And I think that's really important for patients to know, to ask about, to say, is there a study that I should consider? And if so, teach me about what that is.
Yeah, and I would add to that as well is that the only currently known curative treatment for high-risk MDS continues to be bone marrow transplantation. Not everybody is cured, but there's always a chance of being cured. And many patients cannot go to transplant because they are older or they have medical comorbidities that prevent them from going to transplant. But what we have observed is that sometimes doctors in the community forget even to discuss transplant because they perceive it as unlikely to happen because of the patient age. But many big centers will actually do it up to mid to late 70s, and the technical advances in transplant have allowed us to do it more and more often. So I think it's very important for patients to discuss that with their doctor, or ask them to refer them to the big or tertiary centers to talk to a specialist there.
Some of the things to talk about are kind of the biggest challenges that exist in our space, and one of the more difficult MDS lesions are TP53 mutated MDS. And this particular population of disease is just really resistant to therapies and will come back even after transplant. So we've learned that we've had some pretty novel therapies that have emerged, and despite testing those in clinical trials, we've seen, again, nice response rates in the early studies, but not revealing any improvement or change in overall survival. So now I think there are some novel therapies that are emerging, whether it's new TP53 modulators, which we're excited to hear about, I think is ongoing at your institution at Yale. So maybe you want to talk about that.
Yeah, so I think there is a number of those kind of trials where we try to target like specific subsets. So I think the message is that not all patients should be treated the same way. There is significant variation and heterogeneity within MDS, so it's very important for the patients to ask their doctors about what is their risk score and what is their genetic markers, because those could affect multiple aspects, including going to transplant, including what clinical trials are available. So there are certain mutations that already have approved therapies, like IDH mutations. These were primarily approved based on AML data, but we actually use them in MDS. They are not very common, but we do see them. As Dr. Carraway mentioned, TB53 has been a very difficult disease to treat, but there are a number of kind of evolving approaches. This is a subset of patients that I think should really try to get treated in bigger centers because the outcomes have not been great. And sometimes there has been reluctance in the community to treat these patients because of the concern about their outcomes. AML and MDS occur on a continuum, and very important to think about lower risk versus higher risk. In lower risk, the treatment goal is to improve blood counts and improve quality of life. So we had actually a good success with a number of agents over the last 5 years, such as luspatercept and imetelstat. And in high risk MDS, on the other hand, the success has not been there to the same degree, but we are seeing some improvement. For example, oral versions of the hypomethylating agents. There's already an approved version of oral version of decitabine. There is an oral version of azacitidine that's also being developed, and those are important not only because they can make the time that the patients spend in the clinic less, and potentially could improve what we call time toxicity, spending too much time in the infusion suites or in the clinics, but also they could serve as a backbone to add in additional treatments without making it very challenging for patients to come. So there have been a number of trials looking at adding other agents such as venetoclax, which is an oral drug that has shown success in AML, but the phase 3 in MDS was unsuccessful. However, we do think that there could be some patient populations who could benefit from these treatments. So I think, again, this is why it's important to kind of have at least a second opinion in the big center with experts who know the disease very well, because there's a lot of complexities involved.
I would agree with that. And, I think the other thing that we talked quite a bit about today is we care a lot about patient-reported outcomes and symptoms. And so this is something that would really be beneficial to the research that's going on, is to really engage the patients in making sure that if there are questionnaires about their quality of life and or patient-reported outcomes, that data is incredibly meaningful to our clinical trials and is really important whether you're on a new therapy or on even standard of care. If there's a clinical trial that helps us to evaluate what therapies are improving quality of life, we really need to make sure that patients are part of that process and engaged.